All right, so let's take a look at how iTrace helps in refractive surgery there. So I've got three case presentations to share with you. This is a 46-year-old female, status post myopic PRK elsewhere back in 2007. Came to me in July of 22, and I chose to do a PRK for her. It was a hyperopic mixed astigmatism enhancement. Choosing blended vision there, near right eye, distance left eye. She had 20/20 potential. She was 46 years old, so mistake number one I made, I'll confess, is I didn't do an iTrace pre-op. Not sure we've shown anything, but it'd been good to have had it, because you'll see why here. So 3 months out, she's pretty happy. She's J1 in her near eye, 20/30 in her distance. She's lost a line of best corrected visual acuity to 20/25. And you can see she's on goal, a -1/4. But another 6 months later, she's not happy with post-op glare to 20/50, nearsightedness. She's a -175. Okay, she had a 2+ nuclear sclerotic and cortical cataract, and that took her down the path to a light adjustable lens. Let's look at some of the testing. So this was her pre-op Pentacam. Rather unremarkable with all the patterns that we see here. So I felt she was a good candidate for PRK. Epithelial thickness map gave us the expected hyperplasia of the epithelium where the ablation had been done, so nothing out of the ordinary there. This is her iTrace pre the IOL. So this is 9 months after she had gone through that PRK, and she's actually active in the military. So that was a little bit difficult for her with time off, et cetera, for recovering from PRK. And look at her left eye, her dominant eye. No wonder she's complaining with the aberrations we have from the cornea, okay, where we have some asymmetrical, non-orthogonal astigmatism. We can see bottom left. And her lens dysfunctions at that 4.98 in the middle of the top right there. I'm not sure this pointer, oh, there it is, okay, yeah, so the 4.98. So you can see how she's seeing. So we understand why she's not too happy, even though the grade doesn't suggest she has too much cataract, dilated. I saw what she had. So post light adjustable lens, she's a 10. I told her to go home and tell her husband that she's a 10. So yeah, she's very happy about that. But of course, what happens in one eye usually happens in the other eye. So in her right eye, you can see her lens dysfunction has gone to a 4.6. Cornea looks pretty good, but she headed to a light adjustable lens with it. So onto that light adjustable lens for near for her. So I would say, when we do an enhancement on somebody, we're not expecting to need to do a cataract procedure within a year for them. So this happens less than 1% of the time in our corneal refractive patients. So the take-home message to me from this patient is important to do a pre-op iTrace in all our 40-plus-year-old laser vision correction patients for documentation of the correct procedure chosen for that patient at that time. Ray, if you got anything to add to that, I'll allow you to speak up. Good? Okay. Well, I'll move on to the next. So cataract in a decentered optical zone. This was actually my patient back in 1997. I'm not quite as old as he is. I'm just 2 years behind him. So I carry the red, white, and blue card now. You guys, everybody knows what that is? At least the ones that practice in the United States know that's a Medicare card. Yeah, so post-myopic ALK in 1997, astigmatism correction AK, and also needed an 8-incision RK in the left eye. So he had cataract eval by one of my esteemed partners that's here in the room, who says, I'm going to send this to another of the junior partners there, and that junior partner then referred to me. So yeah, I was the third one down the line there, referred or deferred to me. So looking at this patient, I planned a light adjustable lens in the right. You'll see the decentered optical zone in the left in a moment, and an aphthera lens for the left eye. And so you'll see how good the iTrace is in helping with those patients. So here's our corneal topography, and I look at the CIM, so a little bit of mild irregularity, higher irregularity here in the left eye. And it looks pretty good with the centration and ablation in the right, good candidate for the light adjustable lens, but not the left with this very decentered optical zone that we have. So here's a pre-op iTrace of the right eye. I put a little bit of an LAK, laser astigmatic keratotomy in when I do the femto part of these and let the rest be done with the light adjustable lens. And you can see his lens dysfunction of 6.9 and the overall vision that he has from the cornea and the lens at 4.3. Here's his iTrace in the left eye. You know, this looks like a bit of a nightmare, so I can understand why Dr. Levine wanted me to take ownership of this patient. I took care of, what'd you say, Dr. Levine? Last century. Yes, all mine from last century. Can you imagine that? Okay, so look at look at what this coma is doing. Yes, of all those aberrations on his cornea, and then his lens and the summation of it. And this is a scan at a 3 millimeter pupil size. You can see the aberrations. Almost ran out of room on the scale here for the astigmatism and the coma. It's like some goalposts that somebody took down after a big win. So, predicted improvement in vision with the Apthera IOL. iTrace is fantastic with this. You take the pupil from the 3 millimeter size of the scan here, move it down to 1.5. In iTrace 7.1, Ray doesn't know, but he's promised me that he'll have that 1.4 millimeter setting for us. No, he hasn't promised me that, but it's pretty darn close. We're within 0.1 millimeter, so yeah, 1.5 works, exactly. So if it's not broken, don't fix it. And we can see how we've lessened the aberrations from here to here, and that's even still with the cataract in. So I look forward to getting a good scan, and that's a challenge post-op if you have some ocular surface disease. And once that small aperture is back in the lens, it takes a very skilled technician to do that. So the ones that have done my post-op scan so far did not give me anything acceptable to show you. So that we need some help there from Sanya. So the right eye, this is the right eye post-op, his light adjustable lens. We've lessened his aberrations, but still you can see that things have changed with what he had done on the cornea. So I think he's gone through 2 power adjustments. I'll see him back next Tuesday and see if we can lock in. So iTrace and Apthera IOL planning, it's powerful in showing the patient the possibilities to improve vision quality when the cornea is contributing to the patient's diminished vision with that infinite coma. Adjust the pupil down to 1.5 millimeters. It's in the non-dominant eye. We targeted a -75, and we used Aura. So there's still a few cases to use Aura on. Adjusting the IOL power up a half diopter, and the 2-week post-op refraction was a -1. So looking pretty good with that adjustment there, but have to let him adapt to using it and get the surface better between MIBO and some DE3 omegas. So the last case is where I need your help. So pay close attention to win the consultation prize. So this is a challenge post-hyperopic LASIK, and yes, I did this one in this century. I think it was 2001. So 68-year-old female with the post-hyperopic LASIK in 2001. So March of 23, one of our associates did cataract surgery, put in distance monofocals. Unfortunately, he didn't choose the neutral aberration in Vista there, but chose a spherical aberration correcting lens. Did with the monofocal IOLs, distance both eyes, did YAG capsulotomies 4 months later. In August of 23, the patient's bitterly unhappy, losing confidence in the surgeon, vision without correction, 20/50 minus right, 2200 plus left. You can see the refractive errors, those aren't too impressive. Best corrected visual acuity is 20/30, 20/30 minus, and don't think that's down, but maybe 1 line from where she was pre-op. She saw it second, that was me, and third opinions from the 2 most experienced refractive cataract surgeons in the practice, but really a little too late with that open posterior capsule, lessening our options. So pre-op keratograph, the satellite office he saw this patient in does not have iTrace, so we have to work to get iTraces out there too. Exactly, bring it on. Since I'm out of ownership, I'm out of management, I'm going to endorse getting it, but I'm not the decision maker. You got to work on Dr. Levine.
Okay, we will.
Okay, he can throw his weight around and get it done, right, Ed? Sure. Okay. But there are some tightwads, you got that don't get this. This is a great investment. It will really help you. So yeah, I endorse that. So pre-op keratographs, you can see in looking at the left eye, the right eye looks pretty good over here, but the left eye, we can see that we've got this decentered optical zone, even from the keratograph that's there. Now look at the pre-op IOL-master topography. So it shows a PMD-like appearance to it on the topography that the IOL-master does, and the version they have at that satellite office is newer and does give that kind of information. So that was kind of a warning seeing that. He said, maybe I need to consult somebody more experienced to help me. So now 1 month out, here's a post-op iTrace, and it's rather surprising about how well the patient's doing it 1 month out. She was happy then. So we see that that cornea has changed favorably, even maybe did some minimal LAK there for her, and it looks like her aberrations are much down. So these are really looking like a pretty good result, and she's pretty happy at that point. The aberrations have gone way low, don't have the pre to compare to. And the post-op corneal topography, we have seen that we just have some mild irregular astigmatism with it, but it's showing here at this point more of that decentered optical zone effect in the left eye than the right eye. Epithelial thickness map. This is not what we would expect for somebody who's had a hyperopic LASIK procedure. There we would expect to see some thinning over the steepest area here or here, but we see thickening, and this is also post-op after cataract surgery. So I think a lot of this lies in the epithelium, where we have to do serial epithelial maps and follow it to see where she'll end up. You'll see what I recommend here. So post-op LipiView, I like to use these numbers as this is your percentage of oil thickness. We expect 100 plus. You're like 75% of normal, 63% of normal. People get percentages. And then of course we'll also look at the partial blinking, and then we'll look at the structure of the oil glands, and these actually look pretty good. So don't think this patient has a lot of evaporative dry eyes. This is backed up by the TFAs, okay? That's not the TSA we all had to go through, that's the TFAs, okay? And I call a 9 to 10 an excellent score. 8 to 9 good, under 8 we've got some improvement we need to do. So I just kind of simplify it that way with the numbers, but we heard today that patients understand and get looking at the placido rings. So they can understand if these are interrupted a little, that's dryness is doing it. Of course, the eyelashes up here, but that's dryness that's giving some distortion to these rings of light that should be perfect on your eye. So 5 months post-op, the right eye is still pretty good. I think this was after the patient was dilated there, and you see the topography, but we now see this cornea going back to all that coma and decentration, and look how things went downhill from 1 month to 4 months as that epithelium was doing its changes. And the aberrations have started to increase again for astigmatism in particular, coma up a little bit in the left eye, but we're back to seeing that decentered optical zone that really is her problem. We looked at eye design, more because she wasn't necessarily a candidate with a topalizer not matching up to use the EX500, but to look about could we do a wavefront guided enhancement for her to help her. And so that's why we looked at the eye designs. And the left eye had a pretty good match. Pentacam post-op, nothing had really changed there other than she'd gone back to the decentered ablation. So my recommendation was that we do an eye design enhancement in the left eye. We can debate flap lift versus PRK. I would do a plus 75 adjustment. She wants more distance. If anything, when we do these, we tend to see drifts to the far-sighted sides. I think she'll get better distance and still have good intermediate vision with that slight blend, lessen aberrations that are really the source of her discontent. Now the other option, is much, would take a lot more courage. I'll use that politically correct term there. Or an IOL exchange with an Apthera in the bag with an open capsule. A bit of a challenge with the vitreous coming forward. I'm not sure I'm ready to man up and do that. What would her vision quality potentially look like? Well, we have a tool that can give us that. So here is the 1.5 millimeter iTrace for her. And look how much better she would look than she was pre-op or the most recent post-op from that. I didn't put them side by side here, but this is much improved from what we saw back in the past. The third opinion, not from Dr. Levine, but from Dr. Jane, he suggests just observe for stability, wear your glasses, And this is what this highly disgruntled patient chose to do, as she is fearful of additional procedures. What would you do if this was your patient? Anybody got thoughts? Yes, sir.
I would put a contact lens on.
Okay. And of course, she says she doesn't want any contact lenses.
No.
She's, yeah, yeah.
It's
But,
just for
right, yeah,
vision.
sure, okay, gotcha. Mhm.
Eliminate the corneal problem and see what's left.
Gotcha. So, yes, so certainly a gas perm, contact lens over refractive C. It's a good idea. Anybody else with other suggestions to help in this minor? Of course, I'm going to give that advice to Dr. Jane because it's his patient now. So, so let's see. So kind of my bottom line message to you is iTrace education is never ending. I think I may be in my third decade of coming to iTrace education meetings there. So yeah, I'm showing my age. So, Any questions?